So we'll start with the FMGE Predictor 2026. The subject today that I'll be dealing with is dermatology. I'm Dr. Jazeer, your dermatology faculty at PW Medit. Today, the basic idea is that I am having almost 35 to 40 questions, which will be discussed from the most important topics today. Thank you, Kavya, for confirming. So now let's begin with the first thing. So the idea here is we will cover most of the topics in dermatology through around 30 to 35 questions. And whenever you know the answer, please feel free to answer me in the chat box. And even if you make a mistakes, we'll correct all those mistakes today and proceed further. Clear? So now let's begin. The first question here is that a 55-year-old female patient presents with a known case of ovarian cancer. So I'll just highlight whatever words I feel is a buzzword. So a female who is 55-year-old with an ovarian cancer presents with difficulty in activities like climbing the stairs, getting up from a chair, combing the hair, etc. So it's mostly showing that there is a muscle weakness. The following characteristic sign was found on examination. The most probable diagnosis. Now, can you just let me know what is the correct answer here? I'll just zoom this image for you. Imagine that there is a patient who is having a complaint of muscle weakness. Because of muscle weakness, there is a difficulty in climbing the stairs or combing the hairs. So all these things are showing a proximal muscle weakness, right? So what could be the diagnosis here? And this image, it's a very, very typical image. It was asked in the FMG exam in the previous years as well. So what could be the answer? This image is going to show, what is it? So this image is the Gottron's papules. So why am I able to say that this is a Gottron's papule? Just by seeing the image. The reason is I can see that the rashes are present over the joints, like the knuckles, isn't it? The distal interphalangeal joints and all the interphalangeal joints are being affected here. So this one is the Gottron's papule. And where do you see a Gottron's papule? Yeah. Is it seen in systemic lupus erythematosus or dermatomyositis or systemic sclerosis or Cushing syndrome? Yeah, very good. I'm getting the answer as B, and B is the correct answer here. Okay, very good. So that is going to be dermatomyositis. So please remember, this is a case of dermatomyositis. The mention about ovarian cancer here, because it is dermatomyositis is a disease which can be associated with various malignancy, right? So here the question shows ovarian cancer. So now moving to the next one. A child is brought to the pediatrician's office with the following findings. According to the mother, they began as blisters 4 days ago and burst the night before. What organism is most likely to cause this condition? And when I see all the options are going to be a bacteria like Streptococcus agalactiae, Staphylococcus aureus, Streptococcus pyogenes, and Staphylococcus epidermidis. So these are the 4 options now. So thank you so much, Mini Vlogs. I don't know your name, but keep going, and I'm sure that you must be preparing for your NEET PG now, right? So now let's see. Now just see this image. What is the diagnosis here? A child is developing this kind of a symptom, and this lesion has, it is break. The lesion burst a night before. So just imagine that there was a bullous lesion over the skin, and this bullous lesion over the skin has burst the night before. So what is this infection where there can be a bullous lesion in the trunk of a child? Anyone? What could be the diagnosis here? The diagnosis here should be a bullous impetigo. It should be a bullous impetigo, right? And what is the causative in a bullous impetigo? So please remember, if a child presents to you with bullous lesion, one of the differential diagnosis should be a bullous impetigo, and bullous impetigo is caused by Staphylococcus aureus. It is caused by Staphylococcus aureus. So it's a direct question actually. The only thing is that you have to see this image and you have to make out the diagnosis that this is a bullous impetigo, what we are talking about. Clear? So now moving to the next question now. A 5-year-old child was brought by his mom to the dermatology OPD with the complaints of chest tightness, wheeze, cough, shortness of breath for the last 2 months. For the same period, the child also had a gritty sensation and a dry eyes. Similar complaints were found in a grandfather for 40 years. What will be the skin manifestation of the diagnosed skin condition? Any idea what this could be? Because just see, it's a long question and a bit non-specific when you read it as well. Now here, the family history is shown not in the father or mother. There is a mention of a grandfather who is having a similar complaints. So remember, when a grandfather is mentioned, it is something that is hinting that there is a family history. And see what is the complaint? It is again a child, some chest tightness, wheezing, and shortness of breath. When you say wheeze and shortness of breath, we are talking about bronchial asthma. And when we see that the child is having a gritty sensation and a dry eyes, it is mostly mentioning that there is going to be a dry skin as well. Now, are you able to correlate dry skin, bronchial asthma, and a family history? All those things could be. Rajat says it is C. I hope all of you will agree with Rajat. Yes, very good. The answer should be atopic dermatitis. So please remember, in the cases of atopic dermatitis, it's a very frequently repeated topic. So atopic dermatitis always presents to you with a dry skin along with severe itching, and there is going to be always a personal or a family history of atopy. Can be atopy. So on the day of the exam, this atopy can be different diseases. It can be either a bronchial asthma or it can be allergic rhinitis. Allergic rhinitis. So whatever combination comes for your exam. So please make sure that when you see these kind of a presentation together, the answer should be atopic dermatitis. Clear? So Subha, Rajat, all of you are answering it right. Excellent. Now let's keep going. What is the diagnosis for a patient who has multiple painful blisters on an erythematous base aligned along a dermatome on the trunk? An image is also given. Pretty direct question. Anybody who has done this topic once should be able to answer. You have all the keywords here, that there are blisters which is painful, and these blisters are present on an erythematous base. Most important keyword in this MCQ is the dermatomal distribution. Now what is the answer? Yeah, Rajat, Puneet, all of you are answering it as option B, and the correct answer is also option B. This herpes zoster, it is also called as shingles, right? It is also called as a shingles. Now what is the shingles? This is going to be the reactivation. It is a reactivation of the varicella virus. So when a patient gets chickenpox, when the chickenpox has healed several years down the line, when the chickenpox virus will get reactivated, this is called as herpes zoster or shingles. A direct question, and here you can see that the thoracic vertebra is also involved. That is going to be the most common site. And any idea what could be the treatment of a patient who comes to you with herpes zoster or shingles? What could be the treatment? For example, if they ask you a direct question, how do we manage this case for the exam? So if you get a question like that, your answer should be acyclovir. And since these vesicles are painful, more than pain, the patient will say there is a burning sensation. Okay, if there's a burning sensation, then you should also add a gabapentin to acyclovir. So acyclovir plus gabapentin, it should be the management of herpes zoster. Can I move to the next one? So with your permission, let me go to the next question. A 28-year-old female presents with a erythematous plaques covered with silvery white scaling. Again, direct, right? The moment you see silvery white scaling, that too over the extensor surfaces. What is a likely diagnosis? A punctate pitting was noted on examining the nails as well. What is a likely diagnosis? Got 205 in FMG first attempt. Congrats, Gautam. Keep going, don't stop here. You have to go and crack NEET PG as well. Chalo. So yes, Puneet is answering, Shubha is answering, Alvin is answering. All of you are saying that it should be option A, that is psoriasis. Exactly. So when you get an image like this for your exam, just see this image. You should have this photographic memory that is working. A red color plaque And above this red color plaque, if you can see some silvery white scaling that is present, then the answer is always, the diagnosis should always be psoriasis. And please remember few points about psoriasis, that if they ask you what is a management, the overall drug of choice in psoriasis should always be methotrexate. Okay, the overall drug of choice should always be a methotrexate. Yes, cool NDA. What we have done is that about 35 questions will be discussed today, and all those questions are from the most probable topics. We'll try to cover whatever is possible, but in between, if you have any doubts, please feel free to stop me and answer and question and share the doubts with me as well. Okay. So now let's see the next one. A newborn baby presents to the OPD with a mark on the face as shown below. It's not the face actually. So just correct it. So this is somewhere in the trunk, on the trunk as shown below. What is the probable diagnosis? So if I just zoom this image for you, you can see something like this which is present near to the umbilicus, and it is a very peculiar kind of a lesion. Does it look like a port wine stain or a cavernous hemangioma, a nevus simplex or a capillary hemangioma? What is the answer? I'll just giving you a few seconds to give the answer here. Cavernous hemangioma answers many. Are you sure it is a cavernous hemangioma? So please remember this one. I would say this is a capillary hemangioma. Okay. Yeah, Prajapat is answering it right. Akshat is also getting it right. Okay. So this should be a capillary hemangioma. The reason is it is okay to have a confusion between the cavernous hemangioma and a capillary hemangioma, but capillary hemangioma looks more red in color, whereas if it was a cavernous hemangioma, it should be purple or violaceous, and it should be a large lesion, usually with the ill-defined borders. So if it looks more of red, it should be a capillary hemangioma, and this is also called as a strawberry hemangioma. It is also called as a strawberry hemangioma. Don't get confused about it. So it looks like a strawberry, and the answer should be a capillary hemangioma, which usually does not require a treatment, because what happens here is these lesions, they are bound to regress. Okay, and they will be regressing by approximately 10 to 12 years of age. They regress by 10 to 12 years of age. That is called as a capillary hemangioma. Clear? Moving further, which of the following findings in a 17-year-old female patient is indicative of the primary stage of the disease? You can see the image is given, and you can see a lot of lesions over the face. Now, when you see this image of the face, first thing you have to reach out to a diagnosis. यहाँ पे क्या होगा diagnosis? Like in the face, there are multiple lesions that is present. Same simple thing, right? Because what we call usually as a pimple. So these pimples are called as acne. So यहाँ पे diagnosis है acne. So in acne, what is indicative of the primary stage of the disease? Is it a papule? Is it a pustule? Some abscess or a comedones? Yeah, Puneet says it is comedone. Dr. Inara Simha, Avinay, all of you are answering. Yeah, so here the correct answer should be a comedone, because these comedones, they are the non-inflammatory lesions, and these comedones, they are seen in the primary stage of the disease. So you, all of you should be remembering that there are different types of comedones that we can see. How many types of comedones do we have? So these comedones, they can be of two types. So just remember, one can be a black heads, the other one can be a white heads. Black heads or white heads. In the MCQ, they may mention, rather than mentioning a black head, they may mention as a open comedone, and white heads would be a closed comedones. Closed comedones. So these are the two types of comedones, and please remember, no voice here, please check. Can anybody confirm if I'm audible? I think it's a problem at your end, Singh. Can you please check? Yeah, others are confirming that there is no issues. So this is called as a blackheads or a open comedone. Whiteheads are also called as a closed comedones, and they represent the primary stage of the disease in acne vulgaris. Now moving to the next one. A 43-year-old patient presented with itchy lesions as shown below. What is the diagnosis? See, this is the area where you have to always remember, when you get an image in dermatology, always try to describe the image, because the question says hardly anything. It only says that it is a itchy lesion. So when you describe, will you describe this lesion as a red color papules, or a violet or a violaceous or a purple color lesions? What is it? Yeah, it looks more of a violaceous or a purple color lesions, right? So when you see these kind of violaceous or a purple color lesion over the trunk or over the extremities of the patient, what is the most likely diagnosis? Can it be a scabies, or could it be lichen planus, psoriasis, or warts? Yeah, Prajapat says it should be a lichen planus, right? So lichen planus, remember, they are itchy lesions and they look purple or violaceous in appearance, and they're extremely itchy as well. So this fits mostly into lichen planus. One quick question before we go to the next one. In lichen planus, what is the most common infection that is associated? What is the most common infection that is associated with a lichen planus patient? If you want clue, I can ask you multiple options. I can give you, like, is it a streptococcal infection? Is it a human herpes virus infection? Or is it a hepatitis C? Or is it hepatitis C? Yeah, so this one, it could be hepatitis C is the most common association with in patients who are having a lichen planus. Is that clear? So now moving further, the next question says, a 35-year-old truck driver with a history of unprotected sex with multiple sex partners presents to the dermatology department. Now, when you see all these key points like an unprotected sex, multiple partners, so we are anyways talking about a sexually transmitted infection, right? And the question says it's a truck driver as well. Now, what is being shown is not the genitalia. Instead, you can see the palms of the patient. In the palms, what I can see here is there are multiple colored lesions over the palms. So when you see these kind of multiple colored pigmented lesions over the palms as well as the soles, then what are we talking about? Are we talking about secondary syphilis, lichen planus, scabies, or psoriasis? So there is only one that is given here, right? Which is a sexually transmitted infection, and this should be secondary syphilis. And this image which had come as a PYQ in FMG exam, these are pigmented rashes over the palms and soles. These are pigmented rashes over the palms and soles. One quick question before I go to the next question is, in the same patient, if they ask you what are you expecting as a lesion in the genitalia, so genital lesions in secondary syphilis, what is the genital lesion in secondary syphilis? Are you going to see a genital ulcer in secondary syphilis? No, right? Because genital ulcer is seen in primary syphilis. In secondary syphilis, you have some other finding in the genitalia. Can anybody answer? Just try to brainstorm what could be the answer in a secondary syphilis genital lesion. Yeah, here this is something called as condyloma. So this condyloma, is it acuminata or condyloma lata? Yes. So this one should be a condyloma lata. So condyloma lata is seen as a genital lesion in secondary syphilis, but I have used, yes, Taran. This chancre is seen in the initial phase, that is primary lesion, right? And Hylock is also answering it correct. So all of you are getting it right. So please remember, primary syphilis, the very important thing that you should have a good clarity. Primary syphilis will present as a genital ulcer, which is also called as a hard chancre. But in the secondary syphilis, there is no ulcer. In secondary syphilis, you get a lot of skin lesions like the pigmented lesions over the palms and soles. So moving further, the next question is anti-IgE monoclonal antibody is used in the treatment of refractory cases of urticaria. So which one is used? Like basically what we are asking is what is a biological agent that is used in the cases of urticaria? Is it omalizumab, etanercept, adalimumab, or infliximab? Let's see who is able to answer. I'll give you a few seconds to answer this question. Coffee scrubs say it is A. Puneet also says it is A. We have maximum answer which is going towards A. Inara is also saying A. Absolutely. It is going to be omalizumab. So omalizumab is an anti-IgE monoclonal antibody, and whereas all the other options that is given here like the etanercept, adalimumab and infliximab, they all are used in a condition called as psoriasis. All are used in psoriasis. So if you have watched the lectures, I have given you some mnemonics to remember. How do you remember the biological agents in psoriasis? You can remember it as A, E, I, right? The vowels, not all the vowels, but the initial few. So adalimumab, etanercept, infliximab, all those things are used in the cases of psoriasis. And omalizumab is used in cases of urticaria. But for your exam, in case the examiner is not going a bit difficult like biological agents, instead they are asking you, what is the drug of choice in urticaria? Simple question. What is the drug of choice in urticaria? Would you like to go for a steroids, or would you like to go for antihistamines, or some moisturizers, or something else, or phototherapy maybe? What is the answer? What is the drug of choice in a simple urticaria? Just giving you few seconds to answer in the chat box. Just give it a try. It's okay even if you make a mistake. So what is it? Yeah, here the drug of choice should be antihistamines. You know names of antihistamines like levocetirizine, cetirizine, loratadine, fexofenadine, all those things. So here the answer should be antihistamine. So Alvin, Taran, say all of you are answering. Yeah, Puneet, Hilok, Rangesh, very good. So that should be the drug of choice in urticaria. Moving further, identify the lesion that is shown in the image given below. Now what do you see in this image? You can see that there is a child here and there is a reddish kind of a lesion that is present over the face of the patient. Now just come back to the options. You can see that the options are port wine stain, melanoma, molluscum contagiosum, squamous cell carcinoma. Now the options is making it more easy because if it was melanoma, it should be usually a black lesion, right? Something that looks like a mole. Molluscum contagiosum usually will present to you with a dome-shaped umbilicated papule, right? There will be a central depression. So there is no dome-shaped papules here. And squamous cell carcinoma, since it's a malignancy, it should be having some disfiguring kind of a lesion. Again, not seen. What is the answer here? Yeah, it is seen in port wine stain. Remember, Portuguese red wine that is spilled over the face. So it is going to be a port wine stain that you can see in this image. And can you tell me any syndrome where you can see a port wine stain? Any syndrome where a port wine stain can be seen? Encephalotrigeminal angiomatosis. Very good, Hylock. Yeah, and the name of the syndrome is going to be Sturge-Weber syndrome, where you can see tram track calcifications and all in the CT scan. So it is going to be Sturge-Weber syndrome. Very good, Rangesh. Excellent. Now we are moving to the next question. Which toxin is involved in the condition shown below, and what is its target protein? Very important topic, I would say, because few days back we had the INI set exam. In the INI set exam also we got a similar topic, the same topic. Let's see who is able to answer. Which toxin is involved? So if you have to say what is the toxin involved, पहले ये बताओ कि condition क्या है? What is the condition? You can see that there is a child here. There is a large peeling of the skin, isn't it? There's a lot of peeling of the skin that is being shown throughout the lesions, right? So can anybody tell me what could be the spot diagnosis in this child? I'm already getting answers here. Yeah. Say, Hylock, Coffee Scrubs, all of you are saying that the answer is option B. Yeah. Ananya Rathor is saying that this is a condition which is called as 4S. So what is 4S? This is staphylococcal scalded skin syndrome. Excellent. So when you see that a child is having a massive peeling of the skin, usually without a mucosal involvement, and since it is caused by staphylococcal toxins, the child may also have fever, right? So this is a presentation of a staphylococcal scalded skin syndrome. And as all of you are answering it here, yeah, Himan, Phantom Lancer, all of you are answering it. Say that is it is going to be 4S. And what is the toxin that is associated? Is it TSST or is it exfolia toxin? Yeah, it could be exfolia toxin, right? So we have two options which says there is exfolia toxin. Now, in this exfolia toxin, is the defect happening in desmoglein 1 or desmoglein 3? Yes, the defect is happening in desmoglein 1 here. And since only desmoglein 1 is involved, that is the reason why there is no oral mucosal involvement. There is no oral mucosal involvement. So this child, for your exam, please remember how is the presentation going to be? The presentation is going to be fever plus massive peeling of the skin, and there is going to be no oral mucosal involvement. No oral mucosal involvement. So when you see this combination for your exam, think about staphylococcal scalded skin syndrome. Very good. Happy to see that all of you are answering it right. So good thought process. Let's keep going now. What type of eczema is caused by an exposure to a specific allergen? So whenever you have a very specific allergen and if you are developing an eczema, is it because of atopic dermatitis, contact dermatitis, seborrheic dermatitis, or a nummular eczema? Term granulosum. Yes, that is desmoglein 1, right? Hylock. Excellent. Good. Now, what about this answer? Let's say that I have developed a specific allergy to a wristwatch, right? And I'm developing a eczema. So it is going to be very specific. Wristwatch, henna, bindi, or artificial jewelry, footwear, hair dyes. Can give you multiple examples. Specific allergy. Where does it happen? No, don't get it wrong. It is not atopic dermatitis. See, atopic dermatitis may be IgE mediated, isn't it? And it is going to be non-specific. Like the general body, the entire body will be having, there's no specific allergen. Yeah, it should be a contact dermatitis. It should be a contact dermatitis where a patient will be having, somebody is only allergic to a bindi. Why is some patient allergic to bindi? Because they may be allergic to the specific allergen in the bindi like PTBP, para-tertiary butylphenol. Some patient may be specifically allergic to the content of a wristwatch or a belt, the buckle of a belt which may contain nickel. So when it comes to when it comes to a specific allergen, your answer should be contact dermatitis. It should be contact dermatitis. Moving to the next one, a 38-year-old woman has presented with complaints of a painless lesion around the genitals. So when you see these kind of images, the moment you read the first sentence itself, mark the buzzword, at least in your mind. Okay, painless lesion is there. And what is the most likely causative agent of this lesion? But the moment I'm seeing this image, I cannot see any ulcer. Instead, what do I see? I can see that it is a female genitalia and there is some rough surfaced exophytic. Exophytic means which grows outwards, lesions in the genitalia. Now, what is this? Is it caused by a herpes simplex virus or a treponema pallidum which causes syphilis or human papilloma virus which causes warts or Haemophilus ducrei which causes chancroid? Excellent. Range, Shubha, all of them have already answered. Yeah, it should be, what is it? It should be a human papilloma virus, right? So this human papilloma virus, so this is what we call it as a condyloma acuminata. It is called as a condyloma acuminata. This condyloma acuminata, since you already know it is caused by a human papilloma virus, can we go a bit more specific here? Can you tell me which subtype of HPV can cause this condyloma acuminata? Subtype. Like, is it 210? Is it 611? Is it 1618? 3133? I've given you four options as well. The specific human papilloma virus subtype which causes condyloma acuminata. Yes, it should be 6 and 11, which is considered to be a low risk subtype, isn't it? Because it is not going to proceed into any kind of a malignancy. ये तो है, it is going to be a low risk subtype. Very good, excellent. No. So please and do not answer this as 18. Right now it is okay to make mistake. So please remember, if it is going to be 16 and 18 type of HPV, this one you probably must have learned in gynecology, because this is associated with cervical cancer. So this is associated with cervical cancer, and the 16 and 18 is going to be the high risk subtype. Okay, high risk subtype. So I'm sure that you are not going to make this mistake again on the day of the exam. So it's fine right now. So this is going to be 16 and 18. And here the answer is HPV 6 and 11 causing condyloma acuminata. Thank you everyone for answering in the chat box. Now let's go to the next question. A 19-year-old male has presented with a itchy rash in the axillary region. What is the most appropriate treatment? So you already only have one clue here in the MCQ, that the rash is itchy. Now once I'm going to zoom this image for you, I can see that this rash is kind of expanding like this, right? It is going to expand like this. What comes to your mind now? Some itchy rash in the axilla. Would you like to start this patient on a topical terbinafine, which is an antifungal agent? Or do you want to start on a topical steroid creams, or topical permethrin, or oral amoxiclav, which is an antibiotic? Quickly give it a try. I'm giving you few seconds only to answer in the chat box. What could be the answer here? Itchy lesion, axilla, and you can see that it's an expanding lesion as well. The borders are well clear. Ilok says that it looks like a tinea. Do all of you agree? Yes. So Vedant is also answering it as A. So here the correct answer should be a topical terbinafine, isn't it? So it should be a topical terbinafine, because we are suspecting a tinea infection here, which is going to be a dermatophytosis. So dermatophytosis is always itchy, right? It can be seen anywhere in the body. Face में हो सकता है, trunk में हो सकता है, axilla, groin areas में भी हो सकता है, right? But the patient's complaint will be primarily itching. And once the complaint is itching, the next step of management is you will have to go for a KOH test. So this KOH is going to be the investigation of choice. And once you do a KOH test, what are you expecting in a patient who is having dermatophytosis? Here you can see the fungal hyphae. You can see the fungal hyphae. And the answer here in this MCQ was terbinafine. The reason is because the overall drug of choice in all tinea infection is going to be terbinafine. Remember, terbinafine is a drug which is available as a topical cream, as well as it is available as a tablet. So just based on the body surface area, if there is a lot of body surface area that is involved, then go for an oral tablet. If it is a small lesion, you can go for a topical terbinafine. यहाँ पे just remember one additional point for your exam, that the drug of choice in tinea capitis is not terbinafine. Here you just remember it is going to be griseofulvin more than terbinafine. Terbinafine एक second choice हो सकता है. अगर griseofulvin is not given in the option, then you can go for terbinafine. So just remember, every tinea infection, answer is terbinafine. But if the question is about tinea capitis, then the answer should be griseofulvin. Clear? Chalo. Let's go to the next question now. A 24-year-old female has presented with a facial acne. What is the appropriate treatment for this type of acne? Now I'll just zoom this image first. Now what I can see, are you able to see very large lesions here? No, right? So this is not going to be any nodulocystic acne. But instead, there are some lesions which looks like a comedone. There are some lesions which looks like a papule. So it can be a papulopustular acne, let's say. Alright, so it can be a papular acne or a comedonal plus papular acne. Now see the options. Would you like to advise a lifestyle modification or go for some hormonal therapy or apply topical retinoids or start the patient on oral isotretinoin? Very, very important topic. You should go for the exam with a good clarity because you don't want to make mistake in these kind of questions, right? So I'm seeing the answers now in the chat box. Many of you are saying C, some of you are saying D, but most of the answers in the chat box is now C, and I completely agree with you. Go for topical retinoids. So please remember, the drug of choice in all the acne except severe acne. Except severe acne. What do you mean by a severe acne? Severe acne means those large lesions that you can see, like the nodulocystic acne. So in every type of acne vulgaris, always look out for a retinoid, and that too a topical retinoid for the answer. So the answer should be a topical retinoid. And what are the examples? Because on the day of the exam, rather than saying topical retinoids, they may mention topical adapalene, or they may mention topical tretinoin. Tretinoin और isotretinoin में confuse मत होना, because isotretinoin is a oral tablet and tretinoin is a topical agent. So यहाँ पे you should go for this adapalene or tretinoin as an answer. But at the same time, if the MCQ was showing some large lesion, so what should be the drug of choice in nodulocystic acne? Nodulocystic acne. This nodulocystic acne is a severe acne, also called as acne conglobata. Conglobata. यहाँ पे what is the drug of choice? It should be oral retinoid. Oral retinoids. And the example is isotretinoin. Example is isotretinoin. So please make sure that you have this thing in a clarity. Okay. Any MCQ so asking you what is a drug of choice in pimples or acne, always look for this option, retinoid. Answer should be a retinoid. बस इतना डिसाइड करना है कि टॉपिकल एजेंट यूज करना चाहिए या oral agent. Go for topical agent in every type, but when it is very severe, उस time पे the or topical agent may not work, so just go for a oral retinoid. That is a simple explanation for this. So please remember the names of retinoids. Next question. Mother brought her 4-year-old child to the dermatology OPD with a history of a itchy skin lesion and use of steroidal creams. So there was some itchy lesion in the skin, itchy skin lesion, and the mother had used some steroid creams. Now she is saying that after the use of steroidal creams, the child developed the lesion as shown below. So what is it? So just see, the child is having, so which means the lesion is still persisting. The lesion is still persisting in this child, and there is no improvement in the symptoms, right? There is no improvement in the symptoms. What is this? Is it a tinea incognito, or is it tinea cruris, tinea versicolor, or tinea pedis? Ajay, Riyaj, Prajapat, Subha, all of you are answering it as tinea incognito. Excellent. So that is the right thought process here. So this should be a tinea incognito. What do you mean by a tinea incognito? Incognito means this is steroid modified tinea. So this is going to be a steroid modified tinea. So when a child or even an adult is having a fungal infection, should we treat a fungal infection with steroids? Absolutely no. So when you treat a fungal infection with a steroid cream, what happens? The lesion will still be there. Maybe the patient may feel that the itching is now better. The itching has disappeared and all the signs of inflammation may have disappeared, but a steroid cannot kill a fungus. That is why the lesion will still persist. It is called asthenia incognito. It is called asthenia incognito. Next question, what is the likely diagnosis of the image that is given here? See, in this image, we can see there is a black mole, but what I can see in this mole is this area is very dark, right? And this area is very light. And the size of the lesion is also quite big. So when you see a quite bigger lesion, some dark areas, some light color areas in a mole, should we think about a melanoma, a melanocytic nevus, BCC, or a lichen planus? Say, just give me a minute. I will answer you the answer to the previous question about the drug of choice after this. Yeah, all of you are answering it as a melanoma. And remember, many times we have got this kind of a question that just given a question, and when the moment you're able to identify that there's some issue in this lesion, different color, sometimes what happens, the border may be irregular, right? So all those things, you remember the ABCDE algorithm: asymmetrical lesion, border irregularity, color variation, diameter more than 6 mm, and a constantly evolving kind of a lesion. Evolves in color, size, or shape. So when you see all these things, think about malignant melanoma. Think about malignant melanoma. And in the last INI set exam, you also got a question like what is the type of melanoma that you're suspecting when you see this lesion in the extremity. So please remember, melanoma in the extremities. This is the most common type of melanoma in India. So this is the most common type of melanoma in India. So for your exam, if you get an image like the foot of a patient and the foot is having this kind of an image, this kind of a black color lesion. So this is called as acral lentiginous melanoma. Remember, it's the most common type of melanoma in India. Acral means extremity. Acral lentiginous type is the most common type of melanoma in India. Yes, excellent. So someone was asking about the drug of choice in the previous question. See, whenever there is a infection, a tinea infection, here the drug of choice should again be terbinafine. As I have explained earlier, so don't go for itraconazole and all, because itraconazole is an oral agent. So it is less likely that you may have to start on an itraconazole for a child. So here just go for a terbinafine. Moving to the next question now. A 22-year-old male presented to the dermatology OPD with complaints of acne-like lesions in his back. Now see, there is one word here, like, because the examiner is not telling you the patient developed acne in the trunk, right? There is acne-like lesion. His family doctor prescribed him oral steroids for asthma for the past few days. What is the most likely diagnosis based on the history and the image that is given? I'll just zoom this image for you. So when I zoom this image, I can see almost all the lesions here. They are looking almost similar in morphology, right? A similar morphology of lesions can be seen over the trunk, and the question says that the patient has used steroids. What is it? Is it an acneiform eruption? Is it acne vulgaris? Is it a morbilliform eruption or a miliaria? Who can answer? Okay, I'm getting kind of wrong answers here. That is why I'm not commenting. I'm just waiting for the right answer in the chat box. Yeah. So let's see what is happening here. Always remember that when you're going to use a steroid tablet or a steroid cream even, so these steroids, they come with a bunch of side effects. I agree that most of the cases in dermatology, we may be using a steroid, right? But whenever you use a steroid, always be careful. The patient can develop skin atrophy, which is the most common side effect of a steroid cream, isn't it? This patient may develop something like a striae, that is some when the skin gets stretched, you can see that some striae or lines can be seen, or the patient may develop some acne form eruptions, acneiform eruptions. Like once you take a steroid tablet, the patient may develop some acne in the face or some acne in the trunk. So these are called as acneiform eruptions. That is a very, very common type of a side effect that is associated with steroid tablets. Okay, this atrophy is usually seen with topical agents like topical creams. Once you apply a steroid cream, or especially over a longer period of time or in larger quantities, the skin may go into thinning of the skin. The thinning is called as atrophy. But when you take some tablets of steroid, the patient may develop some acneiform eruptions. So here the right answer based on the history of this patient should be a acneiform eruption. Should be a acneiform eruption. Is that clear? Chalo. A 52-year-old female presented with the following features as shown in the image. On evaluation, she has a pain in the distal interphalangeal joint. Pain in the distal interphalangeal joint. What is the most likely diagnosis based on the clinical features and the given image? You can see that the DIP is now inflamed as well, isn't it? So the DIP is inflamed as well. So what is going to be the likely diagnosis? Is it a reactive arthritis, osteoarthritis, rheumatoid arthritis, or psoriatic arthritis? And you have one buzzword or a key point here, that is a DIP, because I don't think that there will be a DIP inflammation in rheumatoid arthritis. Osteoarthritis again can affect other large joints in the body. Reactive arthritis can be seen especially after a gonococcal infection or something, right? So what could be the answer here? Yeah, so Prajapat, Karmad, all of you are answering. It should be a psoriatic arthritis. So please remember, psoriatic arthritis, the patient may present to you with complaints of psoriasis along with joint pains. And this is an example of a seronegative arthritis. It's an example of a seronegative arthritis, and this is going to be psoriatic arthritis, especially because the distal interphalangeal joint, which is the most common joint that is involved in this case. It's the most common joint that is involved. Clear? So now moving to the next question. A patient presented with a following lower limb ulcer with a past history of burns on the same site. What is the most likely diagnosis? Maybe surgery may be kiya hoga. So what is this? Is it a venous ulcer, arterial ulcer, Marjolin's ulcer, or a pressure sore? And the history in this question is so clear, right? Yes, Ajay, HLA 27 is associated with early psoriatic arthritis. Very good. Nail changes bhi hoga in psoriasis. I completely agree with you. Yeah, all of you are saying this is going to be option C, that is Marjolin's ulcer. Because why Marjolin's ulcer? This is, what is it? Marjolin's ulcer, is it a malignant melanoma? Is it a squamous cell carcinoma? Or is it a basal cell carcinoma? Which type of a carcinoma is this? Yeah, Marjolin's ulcer is a squamous cell carcinoma, and which usually develops at the site of burns or scars. So at the site of burns or scars, like imagine that this patient had a burn injury, let's say 10 years ago. Now after 10 years, the patient is developing some fresh changes in this wound. And once you do a biopsy, you get to know that this is a squamous cell carcinoma. And this squamous cell carcinoma that develops at the site of burns or scars is called as a Marjolin's ulcer. Please remember, it is a PYQ. It was asked for the FMG exam in the previous years as well. That's about Marjolin's ulcer. The next question, a female presents with vesicular lesions over the upper lips as shown in the image and target lesions on the extremities. What is the likely diagnosis? Now here you can see the image shows there is multiple vesicular eruptions over the upper lips. So what is this disease? upper lips या lower lips में group of vesicular lesions together. So this image diagnosis should be a herpes simplex virus infection, right? To be more specific, we call it as herpes labialis. We call it as herpes labialis when there is a herpes simplex virus infection over the lips. But the question says that there is another important word that is used here, target lesions. Where exactly do you see a target lesion that is associated with HSV? Because in a patient who is having HSV, these patients may develop a target lesion. And how does a target lesion look like? I'll just draw it here because I don't have an image. Like in the central part, there can be a reddish color along with a rim of erythema. The central part may not be a simple macule because a change in color is called as a macule. Sometimes it can be an elevated lesion like a papule, or it can be a vesicle. So imagine karo, ek vesicle is there. Along with this vesicle, there is a rim of erythema. And this is called as a target lesion. It looks like a target or a iris lesion or a iris lesion or a bullseye lesion. So any of this word, target lesion, iris lesion, bullseye lesion, especially seen after an infection with HSV. So this kind of a lesions, we call it as erythema multiforme. We call it as a erythema multiforme. One of the reasons is an infection. Other reason can be because of drugs as well. So now coming back to the question, Pemphigus vulgaris, erythema multiforme, the dermatitis herpetiformis, bullous pemphigoid. What is the answer here? It should be a erythema multiforme. Clear? Good. 40-year-old truck driver presents with a single painless ulcer. Now we are talking about an ulcer in the oral cavity. On further examination, there is a painless ulcer on the penis. There is a painless ulcer on the penis as well, and at the corners of the mouth, with a history of a sexual intercourse with a sex worker. What is a likely diagnosis? Now, you have a genital ulcer and an extragenital ulcer as well, and both the ulcers are painless. So what is it? Is it herpes labialis, primary syphilis, aphthous ulcers, or a lichen planus? Ajay and Alvin says option B. Prajapat is also saying option B. Yeah, I think Akila and everyone. Yeah, very good. So here the answer should be a primary syphilis. So please remember, in syphilis, you can have a genital ulcer, which is the most common, but sometimes you may get a extragenital ulcer. Extragenital ulcer. And this extragenital ulcer, the most common site can be the lips of the patient. It can be the lips of the patient. So when you see this kind of a scenario, and syphilis, right? So syphilis is a silent disease, S for S. So syphilis will always present to you with a painless ulcer as well. So this history typically is going to match with primary syphilis. Moving to the next one. A 27-year-old individual develops a transient genital ulcer that resolves spontaneously. About 2 weeks later, painful inguinal lymphadenopathy and fever develop. Okay, painful inguinal lymphadenopathy and fever develop. Which Chlamydia trachomatis serovar is responsible for this infection? Now, before we look into the options, we know that this is some disease caused by Chlamydia trachomatis. Tell me in which genital ulcer you get a genital ulcer and a painful lymphadenopathy. What is the diagnosis here? पहले ये बताओ कि diagnosis क्या है? If you want options, I can give you options. Are we talking about syphilis? Are we talking about chancroid? Are we talking about donovenosus or lymphogranuloma venerum or a herpes genitalis? Yeah, all of you are answering what is the correct answer here. But please tell me what is the diagnosis here? The diagnosis here we are talking about is a lymphogranuloma venerum, isn't it? It is called as LGV. So we are talking about LGV in this question. and because the causative organism is mentioned, it is Chlamydia trachomatis. Now see, is it L1, L2, L3, A to C, D to K, or MO? What is it? Yeah. So this one is going to be L1, L2, L3. Please remember one more point here, that is L2 serovar is the most common. Among L1, L2, L3, if they ask you what is the most common, the answer should be L2. And remember, if you have gone through the last year's question paper, the last FMG exam, they asked you a similar question like which serovars is responsible for the infection. Answer is L1, L2, L3. But if they go a bit more deeper, what is the most common serovar? Your answer should be L2. Clear? Moving to the next question. An individual with borderline tuberculoid leprosy who is already receiving a multi-drug therapy. So now we already know that, okay, the examiner is talking about leprosy here. Patient is taking treatment with MDT, develops an acute inflammation of existing skin lesions accompanied by neuritis. The clinical appearance shows erythema and swelling of the previously stable lesion. What is the most appropriate management strategy to prevent a nerve damage and control the acute episode? What is the answer here? First, you know that we are talking about leprosy here, and there is some acute inflammation of the existing skin lesions. And can you be more specific? What exactly are we talking about? Is there any specific thing that we are talking about? Yeah, we are talking about a lepra reaction. Now, in the chat box, please tell me, are we talking about lepra type 1 reaction or a lepra type 2 reaction? The clue here is there is a acute inflammation of the existing skin lesion. मतलब यहाँ पे कोई नया skin lesions नहीं है. Only existing skin lesions are getting inflamed here. So which means we are talking about type 1 lepra reaction, which is also called as a reversal reaction. It's also called as a reversal reaction. Now tell me the answer. Should we continue the multi-drug therapy and increase the clofazimine dosage? Should we stop the multi-drug therapy and start on prednisolone? Should we continue MDT and start prednisolone? Stop MDT. First thing what we should never do is never stop MDT, right? So easily I can easily rule out two of the options. You should always continue MDT. Now what are you going to do? The best answer here, yeah, most of you are answering it as C, and the correct answer is C. Very good. So Vedant, Tulsi, Shubha, Dharma, Prajapat, Rangesh, all of you are answering it right. Coffee scrubs, excellent. So please remember this lepra reaction 1 and 2 is very, very important. Be it 1 or be it 2, in both the lepra reactions, the treatment should be continuing MDT and starting the patient on a steroid like prednisolone. Moving into the next question. A individual reports a high grade fever lasting for 3 days, after which a vesicular rashes appear. Vesicular rash, I got one buzzword. Predominantly centripetal, involving the trunk more than extremities. Based on this presentation, what is a likely diagnosis? Dengue fever, chickenpox, smallpox, measles. Again, a simple question, right? क्योंकि वेसिकुलर लीशंस है, centripetal distribution है, and all those things, this is more consistent with a chicken pox or a varicella infection. So these vesicles that you can see in chicken pox, it's a clinical diagnosis. And how do you make out the clinical diagnosis here? Based on a typical appearance of the vesicle, which is compared to a dewdrop on a rose petal appearance. You can see a dewdrop on a rose petal appearance, which can be seen. Please explain the remaining options. Yeah, because in dengue fever, you don't get a vesicular rash. Dengue fever mein kya hoga? The patient will have fever. Along with fever, there will be arthritis, and the patient will have some rashes. Matlab, there can be a petechial rash. Petechial rash, especially when you're thinking that the platelet count may come down, right? And definitely not smallpox. We don't have cases anymore. And measles will have not vesicular rash. Instead of vesicular rash, we'll be having a maculopapular rashes in measles, right? So here the best answer should be a chickenpox or a varicella. Done. Yedla ready. We will talk about all the other options as well. Now let's see the next question. An individual with an unknown history of rheumatoid arthritis develops a rapidly painful ulcer on the legs. The lesion shows undermined margin with a violaceous border. What is the likely diagnosis? Sure, I get your point, Yedla. We'll do that. Don't worry. So is it a necrotizing fasciitis? Is it a pyoderma gangrenosum, venous ulcer, or ecthyma gangrenosum? Now see the options here. Now here, for me, the most important buzzword here is a rheumatoid arthritis and a painful ulcer in the legs. So when a patient with rheumatoid arthritis presents with a non-healing ulcer, not necessarily the leg, anywhere in the body, then the diagnosis should be, anyone who can answer in the chat box? Yeah, I'm getting two answers in the chat box, B and C. B and C. So the correct answer should be a pyoderma gangrenosum. It should be a pyoderma gangrenosum. Now see, what happens in a pyoderma gangrenosum? This is an example of a neutrophilic dermatitis. And every time you get this pyoderma gangrenosum, remember, they will give you that the patient is a non-case of rheumatoid arthritis, or the patient is a case of irritable bowel disease like Crohn's disease or ulcerative colitis, or some hematological malignancy. Hematological malignancy. So in a patient who is having a rheumatoid arthritis, irritable bowel disease, or a hematological malignancy, when they present to you with a non-healing ulcer, then think about pyoderma gangrenosum. Now see all the options now. Agar this was a patient who was having necrotizing fasciitis, the patient will not say a history of rheumatoid arthritis. Instead, the patient may come to you with a gangrenous skin. Gangrenous skin hota, then it could have been a necrotizing fasciitis. But in necrotizing fasciitis, it has no relation with rheumatoid arthritis. If it was a case of a venous ulcer, the question will never say rheumatoid arthritis. The question may say the patient is a teacher or a housewife or a merchant, because you want to show that the patient is standing for a long period of time. When you stand for a long period of time, the patient is more prone in getting a venous ulcer, mostly because of a varicose veins. And ecthyma gangrenosum. What is ecthyma gangrenosum? Ecthyma gangrenosum is a bacterial infection, isn't it? Especially caused by pseudomonas. यहाँ पे क्या होगा? You may see there is a black colored crust, what we call as a eschar. So all these things are not seen here, because if you can see a black colored crust and all, the answer should have become a ecthyma gangrenosum. So here the right answer should be pyoderma gangrenosum, only because of the clinical history. And what's the clinical history? Rheumatoid arthritis. Tomorrow for your exam, maybe irritable bowel disease or maybe hematological malignancy. ये जो combination है, these diseases with non-healing ulcer, think about pyoderma gangrenosum. Clear? So now moving to the next one. A 65-year-old patient presents with a tense bulla which settled down after some time. Okay, which settled down after some time. What is the most probable diagnosis? Now here the main points are, it's a elderly patient, 65 years is there, and you have a very important point regarding the bulla. The bulla is not a flaccid bulla. Instead, it is a tense bulla. So you can see in the image also, the patient is having some tense bulla over the trunk. So is it because of a dermatitis herpetiformis, or is it because of IgA pemphigoid? Not pemphigoid, IgA pemphigus. Yeah, IgA pemphigus, Pemphigus vulgaris, or a bullous pemphigoid. Who can answer? Prajapat, Harish, Jivita, say, all of you are answering it as bullous pemphigoid. Excellent. Why bullous pemphigoid is the most appropriate fit in this MCQ is because this is a elderly patient and the patient is having a tense bulla. So these 2 points are more than enough for you to answer it as a bullous pemphigoid. In case the patient had a dermatitis herpetiformis, then what could have been the scenario? Because if the patient was having dermatitis herpetiformis, the patient will never have a bulla. Instead, the patient would have a papulovesicles. And this papulovesicles, which get worsened on intake of bro. So what is bro? Barley, rye, oats and wheat. Now here, if it was a dermatitis herpetiformis, like in the option A, so the patient will never develop a bulla. Instead, the patient would develop a papulovesicles in the body, and which gets worsened whenever the patient is going to consume barley, rye, oats or wheat. Now, what is the disease association with dermatitis herpetiformis? This is associated with celiac sprue. It is associated with celiac sprue or a gluten sensitive enteropathy. Gluten sensitive enteropathy. So that is called as dermatitis herpetiformis. Yes, Ajay, Nikolsky negative hoga in the cases of bullous pemphigoid. I completely agree with you. So very good, Tulsi and Harish, all of you who are answering. Coffee scrubs, Shubha, Vedant as well. Now moving to the next question. Which of the following statements is false regarding the image shown below? So we are now looking for an incorrect statement now. Okay. And before we go into the options, when you see the image, can anybody tell me what could be the diagnosis here? Because I would just zoom this image and I can say that this is a patient who is having a brown color hyperpigmentation. It's probably a hyperpigmented patch and seen over the face. Brown hyperpigmented patch in the face. So one single diagnosis, anyone? Yes. So this could be a case of melasma. So always go in this approach, okay? When you see the image, just try to describe, come to a provisional diagnosis, and based on the provisional diagnosis, read out the options. The options are OCP, pregnancy, sunlight are important triggers. Option 2, if it is seen in pregnancy, it is called as cloasma. Option C, Kligman regimen is not the treatment of choice. Option D, hydroquinone is the most commonly used agent in this condition. What could be the answer? Tell me what is a false or incorrect statement here. Yes, the incorrect statement here could be that a Kligman regimen is not the treatment of choice. It is not the treatment of choice. So why is somebody saying option B? See, option B is correct, isn't it? Because melasma in pregnancy, it is definitely called as cloasma. It is called as cloasma. This cloasma is even compared to a mask of pregnancy. So this is going to be compared to a mask of pregnancy as well. It is going to be called as cloasma only. And what is this Kligman regimen? So Kligman regimen, if you don't know what is a Kligman regimen, let me just write down Kligman regimen. This is one of the wonder drug that we have for the management of melasma, because it comes as a combination of 3 different drugs. One is that there will be a steroid like mometasone. Along with steroid, there is going to be a retinoid like tretinoin. And along with this retinoid, there is going to be a hydroquinone as well. Hydroquinone. So steroid plus retinoid plus hydroquinone. So this magic combination, it works wonders in the cases of melasma. This is called as Kligman regimen. It's called as Kligman regimen. So this is not the treatment of choice was mentioned. It is actually a treatment of choice in the cases of melasma. Is that clear? So for the image shown below, which of the following is incorrect? Once again, you need to identify what is the wrong statement. Now first see the image, same approach hoga, right? You're going to see the image and you are going to tell me what is the diagnosis here. And based on the diagnosis, let us read out the options. What is the diagnosis? If you see that in this image, I can see that there's a well circumscribed patchy alopecia in a patient. I can see there's a well circumscribed patchy alopecia in the patient. So when you see a patchy alopecia like this, what it could be? It could be an alopecia areata. It can even be a trichotillomania, right? Because of this patchy alopecia. So now let's read the questions. Options. Exclamation mark hair can be seen in this condition. So this is an exclamation mark. It is seen in alopecia areata for sure. It is a case of androgenic alopecia. So you have your answer already. So that is going to be the incorrect statement here, or which is going to be the odd one out. Let us also read the next option. Treatment of choice is steroids because alopecia areata is a autoimmune disease. We can definitely use steroids for the management. Peribulbar lymphocytes are seen due to autoimmune attack. Yes, it can be seen. When you see this peribulbar lymphocytes, that is why in the histopathological examination of alopecia areata, what can you see? Do anyone remember what is the histopathological finding in alopecia areata? You can see a swarm of bees appearance. You can see a swarm of bees appearance because of the lymphocytic aggregation. So yes, so C, uh, option B is the incorrect statement. U-shape androgenized mostly front side we can see. Yeah, but one moment, Dharmad, please remember, this is not a case of androgenic alopecia. Androgenic alopecia, how is it present? Like in a male pattern baldness or a female pattern baldness, right? The M-shaped pattern, you lose a lot of hair from the scalp, right? That is called as androgenic alopecia. And remember, the drug of choice in alopecia areata, like in this condition, it is going to be a steroid. जैसे ट्राईएम्सिनोलॉन का इंजेक्शंस देते हैं या फिर क्लोबिटाजोल क्रीम अप्लाई करेंगे, all those things are going to be steroids. Moving to the next one now. A 35-year-old female presents with a facial flushing, which is triggered by spicy food. Now, there is a complaint of flushing in a middle-aged patient, and she says that it is getting triggered by spicy food, heat, or alcohol. On examination, she is having erythema, telangiectasia on the cheeks and nose, but no comedones are present. So there is no comedones. She notes that the condition worsened after using a topical steroid cream. What is the diagnosis? Yeah. What is it? So I can see one of you have answered. Tulsi is answering it as C. Let's see the options now. Acne vulgaris, nevus of Ota, rosacea, SLE. Yes, based on all these things, let's say acne vulgaris will always present to you with either a comedones, यहाँ पे comedones नहीं है, there's no comedones, or there should be papules, pustules, nodules and cysts. तो हम easily rule out करेंगे acne vulgaris. It's not acne vulgaris. Option 2 is nevus of Ota. What is nevus of Ota? I used to show like this, Ota in the eyes, O. Nevus of Ota. In the face and the eyes, if there is going to be a blue discoloration, if there is a blue discoloration over the face or the eyes, we call it as nevus of Ota. But here there is no blue color. You can see there is some reddish discoloration can be seen. Option C is rosacea, and every feature of rosacea is mentioned in this MCQ, which is the correct answer here, right? Because there's a flushing in the face triggered by spicy food, alcohol and all, and then even it is not improving with steroids. The answer is going to be rosacea. And why not SLE? Because in SLE there is no trigger or there is no flushing. And if it was SLE, the patient would have said the patient is having photosensitivity, and the image यहाँ पे there could have been some sparing of the nasolabial folds as well, right? So this is not going to be SLE. The correct answer should be a rosacea. Should be a rosacea. Next one. A patient presents with intense nocturnal itching and a small linear ridges. So there is some itching in the night time. There is some linear ridges, in the bracket says burrows, in the finger webs and the wrist flexures. Now you know what is the diagnosis, because the moment you see this word burrow, Just like comedones, है ना? In the previous MCQ, I mentioned about comedone. Comedone is exclusively seen in acne vulgaris. No other disease can show you a comedone. Similarly, no other disease can show you burrows in the skin. So when you see this word burrows, what should be your diagnosis? Your diagnosis should be scabies, right? Very good, Subha. Vedant is also answering. Coffee scrubs is also answering. So if it is going to be scabies, what is the recommended first line treatment? Benzyl benzoate, permethrin, clobetasol, griseofulvin. यहाँ पे what I can easily rule out is a oral griseofulvin क्योंकि ये एंटी फंगल एजेंट है. क्लोबिटासोल क्योंकि ये एक स्टेरॉइड है, राइट? Now I'm left with benzyl benzoate and permethrin. We can use both, okay, in scabies. That is why I'm coming to the best answer now. What should be the best answer? Yeah, as all of you are answered in the chat box, it should be a 5% of permethrin lotion, which is considered to be the drug of choice in all the cases of scabies. In cases of scabies. Moving to the next one. A 10-year-old child presents with a boggy, inflammatory, painful mass on the scalp with hair loss and multiple pustules. What is the most appropriate treatment of choice? Now I'm not going to give you the answer here because this is something which we have discussed in the previous MCQs. Now just try to apply the logic here. 10-year-old child is having a lesion in the scalp. So children having some scalp lesion and the presentation is very typical. Boggy inflammatory swelling. What is the diagnosis that comes to your mind here? What is the diagnosis here? Anyone? I'll be more than happy if you're able to give an answer in the chat box. What is it? Tender boggy inflammation over the scalp. Yes. So this one is going to be chirion. So what is chirion? A very common fungal infection of the scalp seen in children, right? So if it is chirion, very good, Harish. And in a chirion, how are you going to treat the patient? Will you apply a topical ketoconazole? Will you go for an incision and drainage, oral griseofulvin, or are you going for an oral acyclovir? Definitely, I can rule out acyclovir. Hai na? It is not an antiviral thing that you need to give. Now all the remaining, maybe not incision and drainage also. What is this? Are you going to give a ketoconazole or are you going to prescribe griseofulvin? Yes, answer should be C. That is oral griseofulvin. Yade, I told you drug of choice in tinea capitis is griseofulvin. Very good. A 30-year-old male presents with a painless beefy red ulcer. You have some magic words here. Beefy red color ulcer, painless ulcer that bleeds easily on touch. The tissue smear shows Donovan bodies with a safety pin appearance. Remember, you can see something like this, a closed safety pin appearance. What is a causative organism? Before we go into the causative organism, first tell me, based on these features, painless ulcer, red in color, and bleeds to touch. Based on all these things, including Donovan bodies, what is the diagnosis here? The diagnosis should be donovanosis. Remember, donovanosis is also going to cause a genital ulcer disease. Now, what is a causative organism in donovanosis? Is it Haemophilus ducreyi? Haemophilus ducreyi is something that causes chancroid. Ducreyi, crying wala ulcer, painful ulcer. It's seen in chancroid. Hello, next one. Treponema pallidum. So what is the infection that Treponema pallidum will cause? This will cause syphilis. It will cause syphilis. The next one is Klebsiella granulomatis. Are we close now? Yeah. Klebsiella granulomatis is what causes donovanosis. And how about Chlamydia trachomatis? Anyone? The last one. Chlamydia trachomatis. We discussed a few while ago. Chlamydia trachomatis L1, L2, L3 serovars. It can cause LGV. Right? It can cause LGV. So that is going to be, yeah, beefy red color ulcer means always think about donovanosis and it's caused by Klebsiella granulomatis. Moving to the next question, a 25-year-old female presents with a Christmas tree distribution of a fine scaled erythematous papules on her back. She remembers a larger single oval lesion appearing on her chest 1 week prior. What is the diagnosis? Again, a typical clinical history, because I can see again a buzzword here. The buzzword is the Christmas tree pattern of the rash. So when the rash is going to have a Christmas tree pattern and the patient says that there was a single large oval lesion which appeared first 1 week prior. So what is the name of this kind of a lesion? First tell me what is the diagnosis that comes to your mind. If you have gone through this one, is it pityriasis rosea? Is it secondary syphilis, tinea corporis or a gutted psoriasis? Very good. यहाँ पे diagnosis होगा pityriasis rosea because this single oval lesion, it is called as the herald patch or the mother patch. Herald patch or mother patch, and after which there is a Christmas tree pattern of distribution. All these things can be seen in a condition called as pityriasis rosea. Can be seen in pityriasis rosea. Christmas tree gives rose flowers. Is, yeah, Harish is telling one more very important finding here. So there is a collarette of scaling, or sometimes the MCQ can mention there is a cigarette paper scaling. Collarette scaling, cigarette paper scaling, or a peripheral scaling, all these things can be seen in pityriasis rosea. Pityriasis rosea. Clear? So I guess, yeah, this was the last MCQ of the day. And during this entire MCQ discussion, I could see that most of you were very active in the chat box. I hope that we were able to cover most of the important topics in dermatology during our discussion. If there is any specific topic that you want me to discuss, I'll be happy to spend a bit more time with all of you. Otherwise, the way you guys were answering, it is very, very reassuring. Just make sure that the concepts are all correct. Just try to go through all the typical images in dermatology and you are not missing on all the PYQs. At least the last 5 years of PYQs, please go through all of them and then make sure that the concepts are very clear. And before we wind up, just few important things that before you go for your exam, please make sure that you go through topics like psoriasis, which is very, very important. Acne vulgaris, which you always get questions these days, and genital ulcer diseases, genital ulcer disease like painful ulcers, painless ulcers and all. Leprosy, which is again a very, very important topic. Nutritional dermatosis, because topics like pellagra, scurvy, acrodermatitis enteropathica, all these things are repeatedly asked for your exams, right? So I will not say that the remaining topics are not important, but before you go for the exam, please make sure that you go through these very, very important topics, especially vitiligo as well. Okay? So psoriasis, vitiligo, acne vulgaris, genital ulcer disease, leprosy, nutrition dermatitis, all these things are topics which you are not going to omit. You are going to revise it very, very well. Yeah, the questions in the predictor kit is covering almost all the important topics. So thank you, Coffee Scrubs. I wish you all the very best. Do rock the exam and let us know the results that you have cleared it with passing with flying colors. So thank you so much. Yeah, Lichen Planus Ajay. A good thing that you have mentioned. So Lichen Planus as well. So wish you all the very best and thank you for being a very interactive crowd today. Thank you.